Good evening. I'm Dr. Jim Andrews, and I'd like to welcome you to the third edition of ASMI's Master Class series. We've got a great outline tonight with two real important topics and some great speakers. We've assembled these speakers to bring to you the most up-to-date information in these significant problems which include core and hamstring injuries in sports. To get us started, I'm going to introduce our moderator, Dr. Michael Ryan. Mike completed an orthopedic sports medicine fellowship at ASMI in 2017. And he's one of those smart guys that actually did a second fellowship. He went to Bern, Switzerland for a year in 1918 and studied hip preservation surgery under famous Professor Klaus. And now he's on the staff at Andrews Sports Medicine Orthopedic Center, specializing in sports medicine and, of course, hip preservation surgery. He's going to moderate the program for us tonight. At the conclusion of tonight's final talk, we'll have a panel discussion, which again will be led by Dr. Mike Ryan. And you're welcome, and we encourage you to submit questions through the Zoom chat feature, and we'll try to get to as many of your questions as possible. We really don't have a time limit for this program, so as long as we don't go too late, we'll try to get a bunch of questions in. With that, I'm going to turn things over to Dr. Mike Ryan and let him introduce tonight's speakers.
Dr. Andrews, thank you very much. I really appreciate it. For all of those of you, this is a little separate sort of thing, but for anyone who has not checked out the Victory Over Injury podcast by Andrews Sports Medicine, Dr. Andrews is our premier guest, and he's phenomenal. He bestows some incredible wisdom, some great stories. So please go check it out on all the podcast players, Apple, Spotify, Google, etc., and check it out. Thank you. Moving on, tonight's masterclass is very exciting, and our guests are supreme experts in their respective fields. Tonight, we cover some new, intriguing topics concerning the hip and core, and you will not be disappointed. Starting us off, speaking on surgical treatment for core and hamstring injuries is Dr. Benton Emblem. Dr. Emblem is also a graduate of the American Sports Medicine Institute, during which he completed a sports medicine fellowship. He also trained with an additional fellowship with Dr. Thomas Bird, gaining some experience in hip arthroscopy as well. He's an orthopedic surgeon and partner at the Andrews Sports Medicine Orthopedic Center, where he practices as a sports medicine and hip specialist. He is a founder of the Hip Center at Andrews Sports Medicine, where he brings extensive experience and knowledge of the young athlete's hip. In particular, he has exceptional experience with core muscle injuries, hamstring injuries, and hip impingement, and has published several studies on his techniques and outcomes in this arena. He is a team physician along with Dr. Andrews at Auburn University, and is also the team physician at Hoover High School. As an experienced pilot as well, Dr. Emblem will guide us through the surgical treatment of core and hamstring injuries. Following Dr. Emblem is Dr. Kevin Wilk, who will discuss rehabilitation following core injuries and sports pubalgia. Dr. Wilk is one of the most well-known and regarded physical therapists in the business. Having treated countless professional athletes for over 35 years, Dr. Wilk's experience, knowledge, and passion is second to none. He's published extensively in peer-reviewed journals and book chapters and has received numerous awards. Dr. Wilk is the guru of getting well, so please pay attention to him. Finally, closing us out, like he is so comfortable doing, is Jeff Allen. Jeff is the director of sports medicine and head athletic trainer for the 18-time national champion University of Alabama football team, and he's responsible for the physical and mental health of some of the best athletes on the planet. He received the 2019 ALATA Collegiate Athletic Trainer of the Year Award and the 2018 NATA Head Athletic Trainer of the Year Award as well, among many others. Today, Jeff will present his expertise on hamstring injury prevention and rehabilitation. Ladies and gentlemen, thank you again for tuning in tonight, and I hope you enjoy this exceptional panel. Without further ado, Dr. Benton Emblem and the surgical treatment for core and hamstring injuries.
Thank you, Mike. Can everybody see my screen? Great. It's a pleasure to speak to you guys tonight. We have an interesting two topics to talk about, some of the most challenging issues in sports, particularly as it relates to football. I'm going to talk primarily on core muscle injuries. To add in hamstring injuries and surgical treatment would be a lot for 15 minutes, so haste makes waste, and I'm going to try and limit it primarily to the core and let Jeff take it primarily with the hamstring. So in general, we ask ourselves, what exactly is a core muscle injury or a sports hernia? It's been coined a sports hernia for years, but unfortunately, this has been a misnomer. There has been various and different terminologies utilized, particularly Gilmore's groin, described by Dr. Jerry Gilmore in London in 1980, also known as a sportsman's hernia, or for short, a sports hernia, athletic pubalgia, slap shot gut, and more recently popularized a core muscle injury, which is a more accurate term. The understanding of this entity has been evolving. Prior technique descriptions have certainly been vague, and there are multiple other associated potential pathologies. Our current philosophy in terms of an athletic pubalgia or a core muscle injury involves the injury to the common aponeurosis between the rectus abdominis and the adductor longus tendons. These two structures share a common attachment point. They also share a common soft tissue envelope right at attachment to the bone, similar to the rectus femoris or the quadriceps and the patella tendon at the knee, and the Achilles tendon and the plantar fascia at the calcaneus. Athletic activity, typically the ones that are involved with these types of injuries require a significant amount of torque across the aponeurosis and the pubic symphysis. These sports experience higher torques, leading to increased rates of injury, particularly soccer, hockey, football, and even in baseball pitchers. It's a very disabling condition, and there has been recent publication within our medical literature citing early retirement from the NFL with these types of injuries. Historically, standard inguinal hernia repair techniques have been employed with mixed outcomes. These are both open and laparoscopic. Many patients did, however, fail. Dr. Myers has the most comprehensive series of repairs, which varies in both pathology and in technique. His 2008 series included 8,500 patients with 5,500 surgeries. And if you look at the entities within that cohort of patients, the overwhelming majority of those involved rectus abdominis and adductor type pathology. You can see here, most all involvement here involves the attachment point at the pubis, including the rectus and adductor. So from Dr. Meyer's series, we conclude that the majority of athletic pubalgia is from the rectus abdominis and adductor. In his 2000 and 2008 papers, it was clearly highlighted that the involvement of the rectus and the adductor tendon was the site of injury and discouraged inguinal hernia surgeries for the treatment of athletic pubalgia in the absence of a true herniation. However, many athletes with athletic pubalgia or core muscle injuries are still undergoing traditional inguinal hernia repairs for groin pain. But as we said, a sports hernia is not, NOT, not a hernia. It's a core muscle injury. It's an athletic high, quote unquote, groin injury, typically involving a sentinel injury in over 50% of patients that persists and mimics the pain pattern of a traditional inguinal hernia, primarily just in location and worse with exertion. They complain of exertional pain, lack of explosiveness, or an inability to sprint, cut, or change direction effectively. The pain will typically migrate into the lower abdomen and therefore usually is misinterpreted as an inguinal hernia. Sportsmen with hernia-like symptoms, thus the term sports hernia. Pathophysiologically, it involves repetitive, unsustainable loads on the terminal abdominal insertions and adductor origin, more so with hip abduction and extension, and there's an imbalance between the rectus and adductor attachments. We see in some settings reduced hip range of motion, such as with femoroacetabular impingement, and subsequently compensated increased pelvic motion to improve motion, which can lead to injury at the level of the core, particularly at the rectus and adductors. Pathomechanically, this involves an injury or strain to the terminal rectus sheath and the adductor origin. You can see in this figure here, the cover on a baseball is a similar concept in terms of the muscles attached to that ball, and the covering is shared between the two muscular attachments and can tear and extend from one end to the other. The pain distribution is oftentimes in the inguinal region, the lower abdominal area, the adductors, and can even be referred to the genitalia or the medial thigh. On exam, they generally will have localized tenderness over the pubis and tendon attachment of the terminal rectus and or the proximal adductor longus. We oftentimes see pain with resisted sit-ups and hip adduction combined, and we abbreviate that the RAC test, representing resisted adduction crunch test, as you can see here on the upper right. From a diagnostic imaging standpoint, we have a special specific protocol with oblique axial cuts, as you can see in front of you, and it involves injury right there at the common attachment of the rectus and the adductors. As you can see here by the arrows, you have an attachment point of the adductor that's avulsed, significant bone marrow edema at the level of the pubis, bilateral, also represented on this schematic here on the right side. In our series, nearly 70% of these had strongly positive findings as depicted above. You can see here a more significant injury, just like one that Jeff and I actually reviewed today, and an injury to the rectus, of the adductor longus with retraction about 1 centimeter that extends up into the terminal rectus insertion, as you can see on the right side, depicted by the green arrow. In cases with soft findings, such as what you may see there on the left, it's strongly encouraged to employ our other consultants, particularly general surgery, urology, and even gynecology in the female athlete, to make sure we're not missing an atypical hernia, gastrointestinal injury, or a genitourinary problem. Our study that we published in the Orthopedic Journal of Sports Medicine in 2019 looked at 100 competitive athletes, followed the diagnosis, management, operative treatment, and outcomes. We're going to go over that study here shortly. What we looked at was the functional outcomes after sports hernia repair. We assessed recovery and longevity of repairs, determined complication rates and severity of those, and determined predictors of poor outcomes. That was our plan. Surgically, as I mentioned earlier, you can see on the top part of this plan, similar to the knee, you have a common attachment point between the rectus abdominis and the adductor longus at the insertion and respective origin of the adductor. Surgically, we make a limited adductor release. Okay, this is like a gastrocnemius recession in a child, where we lengthen the overall course of the adductor longus. And with that anterior sheath of tissue that we create from the release, we form a reverse turn-up flap, imbricating the rectus abdominis into the pubis, basically creating independent attachment sites of the rectus and the adductor. So there's no longer a push-pull effect here, as one can lead to an injury to the other. You can see here from a surface anatomy standpoint, the vertical line is the pubic symphysis. The slightly oblique line is the proposed surgical incision. This is a left side. This is looking right at the patient from above. You can see here the inguinal ligament is outlined with the Metzenbaum scissors. The Army-Navy retractors have exposed the deep fascia. We're down to the investing aponeurosis of the rectus abdominis and adductor. We've dotted the lateral border of each with a surgical marking pen. We're performing a limited lengthening of the adductor longus, followed by a turn-up flap here onto the rectus at the level of the pubis, and a gel foam sponge to control bleeding, followed by a amniotic membrane sheath that we lay in the bed of our adductor lengthening to prevent scarring and to promote more homogeneous restoration of tendon tissue. Patients were identified in our database using appropriate clinical codes. Telephone interviews were conducted using HIP outcome score questionnaires with additional questions such as complications, sexual or urinary dysfunction, prior or subsequent surgeries, return to play in months, and level of play. Generated a spreadsheet for statistical calculations. We had 102 patients identified with greater than 6 months follow-up at the time of the study. 2 patients were excluded. 1 was a workers' comp, and 1 patient unfortunately expired in a motor vehicle crash. Therefore, we had 100 patients included in the study. Overall, 85% of patients were greater than 6 months post-op. The average follow-up time was essentially 26 months, averaging between 7 and 54 months. The average age at surgery was 26. 6 of these athletes were pro, 42 were collegiate athletes, 12 were high school, and 25 recreational. More males than females at 86%. 9 had undergone prior inguinal hernia repair. 7 had bilateral injury, and 67 had a single surgery, which was the surgery that we performed. 18 had greater than one surgery. And on average, the total number of operations in the entire cohort was 1.3, ranging from 1 to 5. The hip outcome score average was 99%. The sports subscale at 96.4%. The overall functional percentage subjectively 97.5% on a range of 0 to 100. Overall sports functional percentage 91.6%. That's after excluding those unable to participate, and the average time return to sports was 4.2 months. 87% considered their function normal, 8% nearly normal, and 5% abnormal. There was no statistical difference between the unilateral and bilateral group. The complication rate was 7%, including wound infection, re-injury, and 1 reoperation. Of that 7%, that was absolutely 6 complications. 2 were possible re-tears, but not confirmed with surgery. 2 wound infections resolved with antibiotics. 1 symptomatic hematoma that resolved with aspiration, and 1 required a reoperation for heterotopic bone formation. That was in a pro football player that had prior PRP at the acute injury, and 1 of the 3 that was unable to return to sport. Overall, 96.4% were able to return to play. The average return to play was 4 months. 87% required less than 6 months to return to play, and 3 were unable to return to play, as mentioned previously. Return to play greater than 6 months or unable either had prior hernia repair 44% of the time, multiple surgeries nearly 40% of the time, and a fourth of those were female. Of the ones that returned to play greater than 6 months or unable, only 10% of those had the single index surgery. So, in terms of sport function, less than 90% or greater than 90%. And we looked at this in terms of the return to play. The patients that had sports function greater than 90% on average only had 1.15 procedures done totally, including our surgery. The ones that had less than 90% sports function had an average number of procedures of 1.55. Males to females, 97% return to play in males versus 92% in females. And look at those average procedures, 1.1 compared to 1.83. What is the main factor here? Is the main factor the number of procedures? Well, if you look at single versus multiple surgeries, the patients that had 1 operation, all of those returned to play. We mentioned 10% of those it took greater than 6 months, but all of them returned to play. Of the group that had multiple surgeries, only 84% of those returned to play, and their average number of procedures was 2.3. Single surgery versus prior inguinal hernia repair, 100% return to play versus 89%. Single versus inguinal versus multiple. You can see this is a summarization that we just went through. And the important point here to take home is that core muscle injuries can cause significant dysfunction. It was documented in the NFL study. It can cause a premature termination of career and early retirement. On average, these athletes can expect a 3 to 4 month return to full function. The proper diagnosis is critical, and that's the same with anything that we take care of. In patients that have multiple surgeries with prior inguinal hernia repair possibly do significantly worse than patients undergoing a single surgery. But that makes sense. Let's take the elbow, for example. If you have a patient with ulnar nerve entrapment and they get Tommy John surgery, they're much less likely to have a completely unaffected outcome after the ulnar nerve is addressed. The first surgery is the best surgery. So patients who undergo a single surgery do exceptionally well, and it's important to keep that in mind. The appropriate diagnosis is critical. Complications are rare and typically mild. Thank you.
Dr. Emblem, thank you very much. That was an excellent talk. Really like that paper that you have too. The data on that's really compelling. So look forward to getting into that a little bit later. Next up, we have Dr. Kevin Wilk. who is going to be discussing rehabilitation following core injuries and sports pubalgia. Dr. Wilk, thank you very much.
Great. Thanks, Dr. Ryan, and excellent presentation, obviously, by Dr. Imblum. It's certainly a privilege to be with you this evening. What's nice about these webinars is you can take them in wherever you're at. So you can watch these on your board, surfing, or on your couch or in your bed. As Dr. Imblum mentioned, a lot of these injuries, the prevalence has been well stated as far as hip, but as far as some of these core muscle injuries, it's not really well known. There are a few studies, and just communications with physicians have noted that in the NFL, maybe about 10 to 12 go to surgery a year. I think that number is probably higher. Same thing with NHL players as well, as high as 15 a year. As Dr. Imblum mentioned, a lot of times it's this twisting, this forceful type of movement that you see in soccer, hockey, and so forth. Creates a diagnostic dilemma for a physician, but it's also a treatment dilemma for us PTs as well as athletic trainers. So when we talk about the core of the body, so to speak, we have to identify what it is that we're speaking of. So the core of the body, as far as a good definition, would be all the way from the scapula all the way to the gluteal fold. And it's been well documented that a weak core can correlate to many injuries. A weak core can cause scapular dyskinesis, which can lead to hip or ACL type injuries. Weak hips, obviously, and weak posterior chain can cause ACL injuries as well. And it's also been shown that weak hips can also cause shoulder injuries. Does a six-pack mean that you have a strong core? Well, I would submit to you that people like this in your lower right and the three others that you see here probably have a stronger core than the people with the six-pack. So it's core control, the ability to generate force, but core stabilization. This young lady here is using her hands to stabilize in a doorway and is able to bring her legs up and do like a reverse iron cross. She's literally 7.5 years old and she can kind of walk up the wall like this. So aspiring gymnast happens to be my granddaughter. So when we talk about these core muscle injuries, sports hernia, which Dr. Imblum did a great job describing why it's not an accurate term, it's a tough problem for us to rehab due to the pain and the location, as was mentioned. So this adductor rectus abdominis location, if you will. So non-operatively, as was spoken, maybe put on non-steroidals, possibly an injection, but core training, flexibility, and some period of rest as well is necessary, or a surgical intervention if non-op is unsuccessful. If someone goes on and has surgery for athletic pubalgia, basically initially the precautions are to avoid hip and trunk hyperextension, aggressive or strong rectus abdominis contractions, no heavy lifting, and if you are lifting anything of any object, make sure you're doing it properly. No early running, twisting, or pivoting. So in those first couple weeks, we're working on range of motion of the hip, as well as your knee, abdominal region as well, postural education, so you're in good postural position, progressing to mini squats, wall squats, hip internal and external rotation is certainly fine, as well as clams, and core stabilization and activation exercises, which we'll elucidate in a few moments. We'll get the person on a walking or treadmill program, level surfaces, and work toward pelvic tilts. From there, we'll progress to planking type activities, half plank, full plank, prone as well as side planks, lateral slides, beginning some light sit-ups, quadruped position, running on the Alter G, if you will, or in a pool at about 4 weeks, 5 weeks post-op. So this is a mobility plank, if you will. The person's in a prone plank position and basically moving from side to side, forward, back. Bridging is an essential exercise that's necessary for people with core muscle injury, if you will, or lower abdominal strains. That time frame from about 4 weeks to about 10 weeks, we begin with some twisting type movements such as plyometrics, gradually loading the abdominal region and being able to stabilize, doing some specific sport training, and beginning a running program somewhere around 6 to 8 weeks. Partial sit-ups are implemented, as well as side plank and the hip abduction. And as I mentioned, starting a running program somewhere around 8 weeks. As Dr. Imblum mentioned, the average return back to sports is somewhere between 3 and 4 months as a gradual progression. What about training the core? Special considerations for training the core. There's a variety of exercises. We work toward flexibility as well as mobility. And the goal of this session is to talk about some integration, if you will. One of my colleagues here at Champion Sports Medicine, Louis Lipowitz, has come up with a nice Core 4 program, which I'm going to outline now, where he talks about activation, working towards stabilization, integration of movement, and then stabilizing with perturbations and sport-specific and functional activities. So in the initial phase with activation, you're working toward restoring proper breathing, postural alignment, core bracing, lateral hip strength, and education. Typically, exercises include breathing exercises, as you see here, as a person is pressing down on the ball and stabilizing the core, but working toward lower rib cage breathing. Here is a single leg bridge being performed to your right, manual clams being performed by this future Alabama football player, as well as myself doing a plank as well. Dynamic stabilization, what Lewis is doing there is basically imparting a force onto the arms and also the legs, and the person has to stabilize in that position with proper breathing as well. Bridging, we're a big fan of double leg bridging, single leg bridging, manual resistance, as well as mechanical loading through what's called the glute max device as well. Lateral slides, that requires lateral hip strength, but also core stabilization and proper body positioning and posture. Other core stabilization exercises can be done with a physio ball, as you see here. This young lady is stabilizing the ball in a central position, now not allowing it to move. Tough exercise, much more difficult than what it actually looks. Here, Paul Fuller is doing some lateral slides and a lateral lunge with the Vortex, which is a resistance band attached to this device, as you see there. A nice exercise using a foam roller, trying to keep a neutral spine position, is called a bird dog, where he extends contralateral arm and leg, stabilizing his spine, core of his body. We also emphasize hip adduction as well with core programs. So we're looking for the balance between abductors and adductors, and we'll talk about that ratio. This is using a furniture mover, if you will, stabilizing on one leg. We have a piece of TheraBand around the leg that he's stabilizing on, pulling into valgus, and he has to use his hip abductors, external rotators to stabilize as he slides out on his right foot. He can also reverse this, so the band is actually pulling him into a varus position and has to stabilize as well. As I mentioned before, a dead bug type of movement can be done with a nice central positioning of the core as well. As they gain activation and control, we work towards stabilization, and now more plank variations are done, more balance, proprioception, and we integrate unstable surface. This is using a probably looks like a 4 kilo maybe, or maybe a 7 kilo ball. I don't remember now, but probably somewhere around 12, maybe 14 pounds. He's standing on some foam to create an ankle strategy to stabilize. And all he's doing with that medicine ball that's weighted is moving side to side, activating his oblique muscles, but also moving in a horizontal direction. So we can have him squat, go overhead, move side to side, and even a twisting. This is a tough exercise, really demanding as far as the core of your body, stabilization, proprioception, and a lot of lower extremity synergistic patterns. This is a great exercise for hip abductors as well as adductors. So this is a side plank up against the wall, and she does a hip abduction movement. This has been shown to actually have higher glute med activity, but lateral hip musculature on the lower leg. So this is much tougher on her left side than her right hip, which is elevated. This is called a rollout, if you will, a three-dimensional rollout. So this particular type of rolling device actually moves in multiple directions, not just forward. Nice study by Rafael Escamilla when he was here at ASMI showed this is one of the top exercises for recruiting abdominal muscles. This is one of the mobility planks, if you will. So here we're using the blaze pods, which light up. So she has to recognize the one that lights up and has to tap it while maintaining her plank and has to move from side to side. We can also use suspension bands. And this gymnast is suspended onto a stability ball and is doing a push-up into a rollout. So she'll actually move her arms forward into a shoulder flex position while maintaining core stabilization. Another really tough exercise to do. A Copenhagen plank here. So her leg is stabilized onto a box, and she's basically doing a knee thrust on her lower leg. So she's side planking, Copenhagen plank in particular, and doing a knee thrust anterior. We also can't neglect pain-free stretching, working on adductor flexibility, hamstring, as well as quadriceps and lateral hip musculature as well. Many times a frog type of stretch is done for the hip adductors. Also working on hip flexor flexibility and abdominal. Here Paul is illustrating some thoracic spine mobility with threading the needle technique. Here, Brittany is showing threading the needle technique as well, where she's stabilized up against the wall, using her adductor muscles pressing into a soccer ball, using some TheraBand to get some thoracic spine mobility, some mid-back mobility. Do resisted training as well. This is called the Stelt. And what Lewis is doing here is a plank. This interfaces with your iPhone, and it has a program. So as you adjust the plank device, the Stealth, it actually moves. So you're dodging objects and so forth. So it's a motivational type of plank, if you will. So we're emphasizing time, endurance, but they also get points as well. So it's very motivational for people to do over a period of time. This is a side plank. This is another gymnast where she's doing a side row in a side plank position. Really good core stabilization here. Good shoulder position as well. And we can also increase the challenges with this by having her do hip abduction, hip flexion as well. Last phase or so is integration, if you will, where we're starting to do more hinging types of movements, pressing, lunging, and things of this nature. Lewis is using some resistance bands here. This is called the vector system. That's resisting this golfer's rotation, but also resisting the golfer with this posterior band as well. So we're trying to teach him to keep that right foot down, to drive off that right hip and create this torsional load that generates a lot of club speed, if you will. This is a baseball player working on his swing with 3 resistance bands attached. And these go up to 110 pounds of resistance, each one of them. So one is on his knee, one is on the core of his body, so he rotated into it, and one he's holding. A really nice exercise to generate bat speed, which he told me this morning that he's in spring training now, that he really is feeling good in the cages right now with his BP. So these are some standing shoulder thrusts, and you can see this young man here, a baseball player, has a band around the core of his body. So he has to control the rotation. So it's an anti-rotational type of exercise as he does his shoulder thrust. And you can see he struggles a little bit with that. And you'll see another gentleman here, he's not using the landmine, but he's just doing the knee thrust as you see here. So real powerful movement as far as knee flexion, core of the body, and so forth. We still do balance on foam. Here's a star drill, which is very nice to do. And this was I was mentioning before, the suspension band walkouts. This is a really tough exercise on the core of your body, your shoulders as well. These are called airplanes. This is a half airplane. So it's a Romanian deadlift. She's balancing on foam. This is another gymnast that's doing this. So she's in a really nice RDL position there. She's got some resistance band, resisting her shoulder abduction. All these exercises, I might add, are on my Instagram that you're more than welcome to view and utilize. This is the true airplane, if you will, where there's a band where she's in that RDL position, has to stabilize, and horizontally abducts. One of my favorite exercises for the shoulder, hip integration, if you will. Really tough from a balance standpoint. Again, a Copenhagen plank here in a sideline position. The last phase, here we go, is the perturbation. It's just one or two exercises, then I'll wrap up. So now we're going to add in some manual resistance, some perturbations, some reactive tasks, if you will. And again, Louis Lipowitz has done a very nice job outlining this program. And I know he's looking to publish this as well as create a webinar on this for the future. So stay tuned. I think, yep. So here's one of the exercises here. My computer's giving me a little bit of a fit. So what this gentleman is doing, this is actually Louis on the ball. He's kneeling on the stability ball, and he does throws up against the wall. So what he does is baseball style throws, where he throws a ball up against the wall, a 2-pound ball, and at end range will do a rhythmic stabilization. I think with that, I'm going to end there in the interest of time, so we stay on time. And I'm looking forward to Jeff Allen's presentation on hamstring, so I don't want to belabor that at all. So thank you very much for your kind attention.
Kevin, thank you very much. That was excellent, as always. Some great videos, tons of resources there, and we'll get into that a little bit later. And I already have some good questions coming in from that as well. So we'll also move on to wrap this up before we start our panel discussion with Jeff Allen, again, talking on hamstring injury prevention and rehabilitation. Jeff, take it away.
Thank you, Mike. Appreciate it, Dr. Ryan. And let me see if I can get, there we go. Can we see that now? Making sure I'm at the start there. Kevin, that was great. And most of your exercises, I don't think I would enjoy doing any of those exercises. And also, I was going to tell you that I talked to our gymnastics coach, and we want to offer your granddaughter a scholarship. So she's got a full ride to Alabama based on that one picture right there. But obviously honored tonight to be with these guys that do so much for us here, and appreciate all their work for us and their expertise and everything they've taught me and everything that I've learned from them with working with their entire group for the past 14 years. What I was going to touch on tonight real quickly was hamstring injury prevention, and by no means do I have all the answers to this. It's just been an area that we struggle with at times, and an area that we have done a lot of research in and a lot of work in to try to see what we can do to help our athletes across the board, not just football, but all of our athletes. And I'm going to focus on one particular article that you may have seen that I think is really beneficial here. Obviously, I don't have any conflicts of interest related to this presentation. I say that because I am going to show several different devices, and certainly not an advertisement, just some things that we use that are beneficial to us. So with soft tissue injury prevention, just in general, I think it's important to talk about what we do overall. We try to do an analysis on all of our athletes, and certainly all of our football players, when they initially come in, that is composed of a movement screen. We look at core strength. There's several tests that we use to do that. One in particular, a single leg wall sit, that we found really beneficial to evaluate core strength. And then the big one is the evaluation of eccentric hamstring strength. We're big believers in taking a look at that. I love doing movement screens. I think they're really beneficial. Obviously, a little bit beyond the scope of this talk from a time standpoint. I think the key, what I've always thought about movement screens, is there's no one perfect movement screen that out there. You have to decide what best fits for you, for your sport, for your program, logistically, because they can be time consuming. So you don't want to get caught up in the details of that too much, but we try to do just enough to give us an idea, especially with our incoming athletes. Like, for example, we just had 15 mid-year guys come in with football here in January. So we want to take a close look at them and see if there's things that we can start working on, both in the athletic training room and also in the weight room. And then the second part of injury prevention for me with soft tissue is player education. And a lot of that is focused on recovery, but a lot of that is also focused on getting them to understand the importance of doing some of the exercises that we're going to need them to do to prevent soft tissue injuries, and in particular to prevent hamstring injuries. Because just like what Kevin showed, a lot of these exercises, they're not a lot of fun. And I guarantee you, there are exercises that a lot of them haven't really done a lot of. And you'll see what I'm talking about here when we get into that. So we got to focus on educating them about recovery, but also focus on why they should be doing what we're asking them to do. So hamstring injury risk factors. I think we all know this. There's really 5 things if you look at a lot of the research. Age. So I'm definitely going to be prone to a hamstring injury. Previous injury is a huge one. You'll see some of the data on that. High speed running loads. I mean, this guy right here, skill guy, you know that those guys that are running so fast, so much, are going to be predisposed to soft tissue injuries in general, and definitely with hamstrings. And then these are the 2 areas that the article that I'm going to talk about tonight really references: hamstring fascicle length and eccentric hamstring strength. Those 2 are big issues that we need to focus on and see if we can correct and determine who's got issues. So this is the article that I'm going to talk about a lot tonight. And you'll see just about every slide is going to be in a reference to this article. It was out of the British Journal of Sports Medicine. It's 3 or 4 years ago, maybe a little bit older than that, but a really good article that looked at hamstring issues in European soccer players, which obviously has a lot of correlation to just about every sport, certainly to the sport of football. And really what they looked at was eccentric hamstring strength. And was there a correlation? We obviously know there is, but being able to show specific data. And this initial slide, you can see right here that they use the Nord board, which I'll talk about here momentarily, to measure hamstring strength eccentrically. And what they found, you can see that athletes that were below 337 newtons, couldn't produce that amount of force, were about 4 times more likely to suffer a hamstring strain. And they also looked at fascicle length and the relation between that and previous injury. So a couple of things I want you to see on this slide here. You can see what represents an athlete that had a previous hamstring injury versus athletes that had no previous hamstring injury. But look at the bottom here. This is fascicle length of the biceps femoris, and this is the probability of a hamstring injury, what they found. And what you can see is clearly, and this is not something we don't all know, but this is really good data to really be able to show your athletes. If you have shortened fascicle length, if you have a quote unquote tight hamstring, your probability of a hamstring injury is obviously increased, and something that you need to focus on. But you can see the reverse of that. If you can lengthen that hamstring, if you can stretch it, so to speak, and you can definitely lengthen that fascicle area, you're going to definitely decrease your risk of a hamstring strain. So really good information there. And then they clearly looked at eccentric hamstring strength as well. Same thing, you see at the bottom here, eccentric hamstring strength and the probability of a hamstring injury. Again, using the Nord board technology that we'll talk about, previous hamstring injury versus no hamstring injury. You can see this group over here that obviously had very low numbers on the Nord board, had a very high level or high probability of suffering a hamstring strain, especially if they had had a previous injury, which I guarantee you a lot of our athletes, I mean, it's like a common thing. It's like the common cold sometimes. They all have, oh yeah, my hamstrings, I've had a hamstring in the past. And that's like the kiss of death when you hear that. So with those athletes in particular, we really want to spend a lot of time trying to evaluate them and determine what was the cause of that and how do we prevent that moving forward. Because we know that previous injury, there's a high likelihood that they're going to get it again if we don't fix it. But if we can get it corrected, if we can get that eccentric strength corrected, even if they have had a previous history, we feel like we can control that and minimize the risk. This is an interesting slide here, interesting graph that comes from that same article. And what I want you to pay attention to here, all the dots represent an athlete that the article followed. Green means they were uninjured. Red means they suffered an injury. And look, all the ones that suffered an injury, look at the quadrant that they were in, kind of what the article referred to as the quadrant of doom, okay? They had short fascicle length and they had weak eccentric strength. So shorter and weaker. And look at all the 39% of the people that athletes that suffered hamstring injuries were in that area right there. So again, this is information that we all know, but it's really interesting when you look at this and you can show this to an athlete, especially after you do your evaluation and you realize and you're able to show them that they're weak. You can show them the likelihood that they're going to have an injury if they don't fix it, because this is sometimes a difficult thing to get them to buy into. So no question, we know that eccentric strength is a problem. And the issue really, to me, we know that eccentric strength and shortened fascicle length are issues. But how do you even evaluate that to begin to know if they have poor eccentric strength? How do you know if they have a shortened fascicle? So that is a difficult thing to look at. It requires a lot of technology. A lot of times it's cost prohibitive. What I tell people all the time is assume that they're all weak. Assume that they all are shortened and focus on some eccentric strengthening, because guarantee you most of them are very weak eccentrically, because it's not something that they spend a lot of time focused on. And it's something that is difficult. You know, you have so many, think about in your weight room with your strength coaches, all the different things that they have to hit to develop athletes. Sometimes this one gets left behind a little bit. So I've always taken the approach that they're all weak and they're all tight, and we need to somehow fix them all or we're going to have some issues. In terms of what we do to evaluate eccentric hamstring strength, we have used this technology. We use it a lot. I'm sure you're familiar with it. It's been out for 5 or 6 years now. It's called the Nord board. It is a great way to evaluate eccentric hamstring strength. You can see I got one of my guys in there. He's just strapped in. It just does your typical Nordic exercise, and it's going to give you a reading for the eccentric strength on both hamstrings. So really good. It'll show you discrepancies, which is a critical risk factor. If you have weakness on your right compared to your left or vice versa, that's another thing that we like to try to correct. But this is a great piece of technology, not a cheap piece of technology, but a really good piece that we found very effective to help us. In terms of specific exercises that we do, a lot of this really bleeds into what Kevin was showing, and I'm not going to show videos here. There's a lot of these you're familiar with, and you've seen a lot of these different exercises before. Just your typical bridge exercises here, but there's a couple of pieces of technology here and rehab equipment that we use that I really like. This for a rolling bridge that I'll show you here in just a second. The Sorinex machine here just to do a typical Nordic exercise. I think with this, a lot of people get confused, and I've had this conversation with a lot of strength coaches and a lot of athletic trainers. Well, we have a glute ham machine, and the glute ham machine is effective and it works, but it doesn't work to me as good as this in terms of eccentrically working those hamstrings. This will get, if you've never used this piece, this will really get it. And then kettlebell swings are something that we've gotten into. You can Google that, like you can Google everything now and figure this out, but the kettlebell swings are really good, a good ballistic exercise using the kettlebells that'll really get a good eccentric contraction and good stretch on those hamstrings. Really good exercise. And this is those two pieces of equipment that I was just talking about here that just shows, the Sorinex for those rolling bridges, if you will. It's about $100. And then this is the device that we use to do a lot of our Nordic work on. We clearly use the Nord board to evaluate them, but just the day-to-day training. We've got a bunch of these in our weight room, and we've got them in the athletic training room too. Just a great piece of equipment to get a really good Nordic exercise. Really a big believer in that exercise. I like it a lot. And that piece of equipment there is around $300. So not too terribly expensive. And this is just showing the Sorinex being used with the bridge exercise, obviously, and he's going to roll it out. Pardon the pictures there. This is one of our managers that I coaxed into doing some eccentric hamstring work. Who probably won't be able to walk for a couple of days after this. But you can see you're familiar with this, and it's a really effective way to work those hamstrings and that posterior chain. And this is just showing the same thing with that Nordic machine there by Sorinex. This is a program, and you feel free to take a picture of any of these slides. I should have told you that from the get-go. Certainly this one. This was a program that I got from Daryl Conway, who's the head athletic trainer at Michigan. And I got this from him 5 or 6 years ago. And he was using it, and we've used it a ton for a long, long time. Really like it a lot. It's called the triple threat. All it requires is a Swiss ball, and you can get some really good work out of them eccentrically, really challenging exercises. And you'll see what I'm talking about here. I'm not going to go through each of these, but again, you feel free to take a picture of this slide if you want to. And pardon the model. Okay, these are not high-level elite athletes. These are football managers that I grabbed off the street and pulled them in here and made them do some work. So their technique's not perfect, but you get the idea of what we're looking at here. But exercise 1 is just a bridge that we're all familiar with, but clearly doing it on the Swiss ball gives an unstable surface, which can obviously increase the difficulty of it. The second phase of that is a leg curl. Again, his hips should be in more of a bridged position. So again, we're not talking about an elite athlete, but he should definitely be in more of a bridge position when he's doing this. But this will light you up. Really, really good exercise. The hip lift, really a single leg bridge is what we're looking here. His hips should be lifted more than this, and he's going to roll that Swiss ball into him. Very difficult. A lot of times they're not prepared to do this exercise initially, and you have to work toward it. But really good way to eccentrically get those hamstrings. So this was interesting too from the article. What do you know? What do you see in our weight rooms a lot of times? And this is not a slap toward any strength coaches or anything along those lines, but it's something that we do need to think about. A lot of times our focus is concentric strength of everything. I think we sometimes we don't spend enough time focusing on eccentric strength across the board, and certainly not when it comes to the posterior chain and in particular with the hamstrings. But what I wanted to show here was what does eccentric hamstring training do for fascicle length? So you think about someone that's got a hamstring or history of hamstring injuries, and what do we tell them a lot of times? Just stretch more, right? Just go stretch. Clearly there's value in static and ballistic stretching, but there's also value in eccentric exercises to lengthen that muscle. And this study really kind of showed that. This was interesting. There is no question that concentric training has been shown to shorten hamstring fascicle lengths. If you look here, see what I'm talking about. This is the fascicle length here, that part that just came up outlined there on the left side of the graph. And look what happens if the program is strictly focused on concentric training. You can see very clearly there that the hamstring fascicle length shortened over that 42-day period. They got shorter when it was a concentric based hamstring program. The opposite was true when it was an eccentric based hamstring program. Fascicle length increased. But here's the interesting thing with that. With eccentric training, it has to be an ongoing training program that requires really continual upkeep, if you will. Because what happens is after a period of time, they will shorten. Again, you can see that right there. There was a 42-day program that when they took some time off, really about 4 weeks off without doing it, their fascicle length shortened to what it was when they first started. So you got to keep these exercises up for them to be effective. The key takeaway from this article, I thought this was really interesting. For every 0.5 centimeter increase in fascicle length, the risk of a hamstring injury was reduced by around 70%. Pretty strong evidence right there that if we can lengthen that muscle through doing these eccentric exercises, you're going to really go a long way in helping prevent some injuries. You know, in terms of programming these things, and I'm running out of time, so I don't want to go too long here. I'm just about done. You do have to be careful with these. We are very careful when it comes to incorporating these exercises on days that we know we're going to have a heavy volume or a heavy practice day, or when we're just starting back into our program. Our strength coaches do a really good job of how they program these eccentric or these Nordic exercises. So you got to be cautious of that. But after about 2 or 3 weeks, they get used to it, and you can really hammer it home. But you don't have to do a lot. This is not something that you have to wear them out on. You just got to have some maintenance work after you get them going. And this is kind of the protocol that we follow. We don't do it a lot, but we do it all year long. And especially with those new guys that we get in who we know are going to be predisposed to an injury if we don't fix it. Those skill guys especially. In conclusion here, there's no doubt when you're talking about hamstring injury prevention that eccentric strength matters. Again, we all know it. We all talk about it. That article, I think, by Timmons really shows that, and is something that I use with our athletes all the time to show them the numbers that you see in the article, and then show them their numbers to motivate them to kind of fix it. And there also, I think this is critical too. If people say, well, I want to increase my hamstring flexibility. You want to do that? Do eccentric work. It will help. And again, you think about, well, I don't have the ability to have a Nord board. You know, I can't do an ultrasound on every player to determine their fascicle length. I don't think you have to do that. I think you assume everybody's weak eccentrically and everybody's tight. And from that, start fixing them and focus on that eccentric work and see if you can make them better. Thank you.
Jeff, thank you very much. That was excellent. To our other panelists, guys, thank you so much. That was some great information from the surgical treatment for core muscle injuries and the core strengthening and rehab after that, as well as our hamstring stuff. So we got some great questions. Let's go ahead and get started with those. One of us from one of our panelists for Dr. Emblem. Why do you tend to see more core muscle injuries in males as opposed to females? This is more for Dr. Emblem. And what are your thoughts on that?
I think obviously, I think it's a function of the number of males that are playing the sports that you typically see those injuries in. I think that's the primary function. I think in general, we see a lot more of these in football and a lot of the explosive contact sports. Most of the sports that females participate in, or in general, are sports that we don't see this as much in. So I think it's just the exposure relative to the sports that they play.
Great. And to continue with you, Dr. Emblem, I think that one of the key points that you mentioned is really honing this diagnosis. The hip has a lot of muscles crossing it, especially the core. There's, the abdominal contents. You mentioned your rack test, which is something you've really developed and honed in on as a key finding. What other specific findings and evaluations do you note that really help you identify and separate a core muscle injury from hip impingement or something else?
Right. I think one of the most significant challenges relative to examining the hip and pelvis is to become comfortable examining the hip and pelvis, and to not be intimidated by the core. It's not an area that most athletic trainers, orthopedic surgeons, physical therapists, et cetera, really thought that they would really be adept at examining when they went into this. It can be a little anxiety provoking in terms of getting close to the midsection, particularly in the opposite sex. So I think establishing a comfort level and doing it well, and being able to really partition the hip and the core separately, and then being able to kind of go through that dichotomy and figure out, is this a hip problem or a core problem or both? But to really, just like any other body part, become comfortable examining the core.
That's great. I think your surgical technique is very interesting as well. And I thought one of the things you mentioned was really trying to eliminate this imbalance by doing that adductor release. One, where did you sort of identify that? Was that something you learned from Dr. Myers, or did you kind of develop that as you saw these injuries more and more? And then two, do you ever notice any sort of adductor weakness related to some of that partial release?
Good question. So similar to what Dr. Andrews mentioned in his podcast that you did, I would tell you that my knowledge of the core has been a compilation of knowledge that I gained from everybody that I've been around, including Dr. Bird, Dr. Myers, Jeff Allen, others, and taking all that information and developing my own conceptual understanding of what happens. And when I first started looking at these, I spent a lot of time in the cadaver lab doing dissections and trying to understand the anatomy around the pelvis. And the first few that we did were primarily involving adductor lengthenings. And what we found was a lot of their adductor pain went away, but they continued to have some lower abdominal pain. So the question was, why do they continue to hurt in the abdomen? And most of these people, like that figure or that picture that I showed, including involving the baseball cover, it's not just an injury to one. It's commonly seen on an MRI where you have an adductor injury and the rectus abdominis is either not looked at or neglected, and that injury can extend up into that. So in the early phases of our understanding, at least me, I thought this was more of an adductor pathology, but quickly learned that these go hand in hand, and it's difficult to injure one without injuring the other, particularly if you're within, say, 2 centimeters of the pubis above or below.
That's great. I mean, I think it's a fantastic technique, and it's been really cool seeing you kind of develop that, and with that, especially with those great results that you had with those athletes. I think the core is a very interesting thing, and one of the questions from Zach Thomas, and this is for everybody on the panel: what is the best way to objectively evaluate pure core strength?
I think I'm going to defer that to Kevin because Kevin obviously has more tools at his disposal to get more objective measurements of that type of strength. But if you were to ask me just off the cuff, I would say that it would need to involve some form of plank. But in terms of measuring raw strength, I think it's very difficult to do. And I think Kevin could probably be better at answering that question more scientifically.
I was hoping you were going to answer that, Dr. Ingram, but yeah, there's been a couple papers actually in the European literature. There's one paper out of Switzerland, one paper out of Germany that have looked at time with a plank. There's a couple papers out of California from Cal State Sacramento as well. And so the time plank seems to be a range that you can use. You can use an objective way of measuring too, because one of the things is if somebody's in a plank, you don't know when the plank actually ends. Are they actually moving? So I actually looked it up because I saw the question. I had put this on my Instagram. There is a device out there that we have in the clinic. It's called the Phoenix, and it's a belt that has a little sensor. And what you do is you just put it around the person's waist, actually above the waist a little bit, and you put it at L1 and T12 intersection, and the sensor goes off once you either go into a flex position or extended position at that segment. So that'll give you an idea when the plank is broken. Because sometimes it's a little hard to tell, especially if there's a shirt on or something like that. So there is a device available out there to objectively measure. Jeff, how do you look at it?
Yeah, one thing that we've had some success with, and this came from Gary Wilkerson. He is the athletic training program director at UT Chattanooga. And I worked with him a long time ago now, but Gary always used a single leg wall squat. Okay, so our typical wall squat that we might have an athlete do, but doing it on a single leg. So you got one leg in that wall squat position, the other leg is just held straight out, and the length of time that they can hold that. And what Gary was able to show just with some data that he did on some athletes at Chattanooga was the inability to hold that single leg for at least 30 seconds really predisposed them to a lower extremity injury, in particular soft tissue injuries, hamstring injuries, quad injuries, you name it. So that's something that we do a lot, and that's part of our assessment. And there's no doubt we have seen that for sure, especially when we first started doing it with guys. You definitely saw it, and now we've gotten a lot better at that, and we've done some different things. This has been years ago, because we were having, and Dr. Emblem can attest to this, a lot of the athletic pubalgia issues, to say the least, in our skill guys. So we went hunting for what's causing this, and core strength in particular was something that we tried to attack, and that was one way that we evaluated, and I think it was pretty effective.
Yeah, so the single wall squat, and then Kevin mentioned the Phoenix. Those are great great modalities to assess that. I'm not sure that I'd be able to do a single leg wall squat at this point in my career, so may have to work on that. Some other great sort of thoughts coming from different questions is, when you look at the athletic pubalgia, one of the questions that came across was, what's the most difficult activity to go back to? And I thought it was interesting too. And when you look at the recovery from this, it's on average, it's about 4 months, which seems to be a little bit quicker than other comparable surgeries around the hip, or if you look at other body parts such as the elbow for UCL and ACL, which tend to be much longer. This again for all the panelists, but Kevin, why don't we start with you? Why, Kevin, do you think that this tends to be a little bit easier or maybe quicker recovery? And what are the last things that tend to be harder for patients to come back with after athletic pubalgia?
Well, I think the hard things that come back to are the problems they had before, is generating a lot of force in an adducted position, bring the leg across the body, similar to a soccer kick or a hockey player, like Dr. Emblem mentioned before, because of the amount of rotation with trunk flexion, like with a slap shot. That's kind of the classic type of movement. So getting them back, but also, one thing we didn't mention, I probably should have put it in my talk, is getting the confidence back in the person after the surgery. So I don't know if you remember that one video I showed where the young man was thrusting up into a flex position with a shoulder. He was one that was lacking some confidence afterwards. And it was just because he had a chronic problem with it and couldn't get over the hump, had seen a bunch of physicians, and finally went to Dr. Emblem, which was identified correctly by him, and had the surgery. But I knew most of his problems was actually a confidence thing, almost like an ACL patient has. and he just didn't have it. So, some of the things we have to do is simulate and make sure there's not pain, but simulate some of the activities that he had problems with before. He is a baseball pitcher, actually competing now and doing very, very well with it. But baseball pitchers generate that force as well. And probably the culprit for him getting the injury, I don't know if you remember him, Dr. Emblem, was his weightlifting. He's just a fanatic with lifting and working out. He works out like 4 hours a day, and he just overdid it.
Yeah, that's a very good point, Kevin. And it's hard to measure. I mean, it's hard to measure confidence level, but I think a large part of that group in that NFL study were unable to return because of pure confidence. And I mean, we've had a couple cases that you and I have worked with in the last year like that have clearly been that and that only.
In that same sort of frame in terms of looking at these core injuries, there's another component to it that was brought up by Celia Shields is when working for the core rehab, are there cues and assessments for pelvic floor function, and is it possible for pelvic floor dysfunctions that could make these core muscle injuries worse or increase the risk of abdominal injuries? Do you tend to see that at all, Kevin?
Yeah, I'm probably going to defer that to Dr. Emblem. When you're evaluating, do you notice a correlation with that or association?
Yeah, I mean, I think pelvic floor injuries are very similar to like eccentric injuries to the hamstring, to be honest with you. I mean, most of those are eccentrics on the abdominal muscles. I mean, you can look at the pelvic floor in two areas, one kind of the lower pelvic floor and then kind of the anterior pelvic floor, which is more the rectus and the obliques. And yeah, absolutely. I mean, patients with a weak pelvic floor and incompetent pelvic floor are absolutely at higher risk for these injuries.
Great. We'll kind of circle back on the athletic pubalgia here in a little bit, but let's move on to some questions on hamstring injuries. Jeff, obviously, there's some questions on how do you assess fascicle length? How do you assess strength if you don't have a NOR board? And I think your point was assume everybody's weak. If that's the case, what's the ideal scenario for you if you have a young athlete in terms of timing to be able to approach the adequate sort of addressment of hamstring weakness and shorten fascicle length? How long do you ideally like before you have them being able to ramp up to full go before a season?
I think it depends. That previous history issue is something that we would really focus on. I mean, that requires nothing other than as a part of their physical. So, if we have an athlete that, let's say we weren't using the NORD board or we weren't evaluating fascicle length, which we don't. We do not do anything relative to fascicle length. We don't evaluate that. I think obviously there's technology with diagnostic ultrasound. It's the way that was deferred to Dr. Emblem on that, but that is the way that's done. But we don't do that with our athletes. We do evaluate eccentric strength. But again, assuming that they're all weak and they're all quote unquote tight, I think a lot of how aggressive we are is really dependent upon the position that they play. Are they a skill player, which we would probably be more cautious with them because we know they're going to be the higher running volume, definitely higher speeds. And do they have a previous injury? So if we have a skill player, we had one of these last year that came in. It was an elite receiver for us, came into us a year ago in January. Great receiver, really, really good, going to be a really good football player for us. Had a terrible history with hamstring injuries, and he was incredibly weak eccentrically. And he was a ticking time bomb, and we had to be really, really cautious with him because he would tell you, yeah, I never could get through a season without having some hamstring issues. So he was weak, and he had a previous history. So we really took our time with that and really took about the first month and a half of his time here before we let him do a lot of high level sprint work. And we felt comfortable that he had been in our program long enough and been doing some eccentric work, which we had never done before. He had not been exposed to that. So it took a little time to get him used to it. And then we felt more comfortable about letting him go. And now he's doing great.
And with that, oh, sorry, go ahead.
I got a question. That graph that you showed with the concentric versus eccentrics, I want to say that was a 42-day training period.
Yeah.
It seemed to flatline about right there. Is that kind of, if you have somebody that's high risk, do you kind of get them in a 42-day period before you really start cutting them loose, or is that too long?
I think that's probably too long, because if you look at that graph, they kind of that hamstring fascicle link, they showed that at about day 14, somewhere in there, you had already made a difference. If you're thorough with your eccentric work, you had made a difference in fascicle length, and it, like you said, it plateaued out over the course of those 42 days. Now, I think they wanted to show that they stopped at 42 days to see what would happen if you quit the program, and it went right back down within a 2 or 3 week period there. So doesn't take long to get it. You just got to keep working to maintain it.
Yeah.
And when you mentioned talking about working, can you give a little bit of specifics, Jeff, on the reps and sets and the number of days per week that you typically work on these eccentrics preseason and then during season?
Yeah. I don't have I think, and this is going off of that slide that I had, that really our strength coaches really handle most of the maintenance work with our entire team. Clearly, we'll deal with the problematic cases or the cases that have had a previous history, but usually it's twice a week. It's certainly in season. It's definitely not going to be any more than twice a week, where we're going to do a lot of heavy eccentric work. And the volume may be a little bit more in the preseason and in the off season, but not really that much. I mean, maybe 3 times a week at most. We're not going to do that a whole lot. But really, what I've noticed with our strength coaches and every staff that we've had, and certainly our new staff here that started with us a year ago, they're trying to do something eccentrically just about in every single workout. It may not be a whole lot, but they're going to challenge them eccentrically every day, and to make sure that they're hitting that somehow. But I don't think you necessarily have to do it every day. I think, hitting it twice a week would probably be adequate.
Great. And with that, is there any role for isometrics in addition to that? This was a question from one of the audience members, Carlo Borovac.
Yeah,
Do you think isos have a role?
Yeah, I think so, for sure. I think especially with some of those bridge exercises and some of the triple threat protocol that I put up there, one of those is really an isometric hold. You're holding it on a Swiss ball, but it's really an isometric hold of that bridge position. So I absolutely think that isometric work can be beneficial.
I think too, Jeff's point, which is excellent. I think also isometric and core stabilization, pelvic control for these hamstring injuries are paramount. So in addition with everything Jeff said, I think you have to control your pelvis and the core of your body with these hamstring injuries in many cases, especially with sprinting, hurdles, things of that nature.
And in that sort of, you mentioned that kind of the relationship with the core and the pelvis and the hamstrings. One of the questions again from Carlo Borbeck was, do you think that anterior and posterior pelvic tilts have an effect on the injury risk or incidence of hamstring problems?
Yeah, I definitely.
Yeah, definitely.
Yeah.
Go ahead, Jeff.
Well, what I was going to start.
I definitely do. That's.
You go ahead, Kevin. Go ahead.
No, you go ahead. Please.
I think we both do. We both absolutely think that anterior and posterior pelvic tilt will affect the hamstring. I mean, if you just look at the anatomy, that's pretty clear. One interesting thing, and I always look at it with our students. You'll have a guy that, man, my hamstring's killing me. My hamstring's killing me. But they don't have a mechanism of injury. They don't remember ever, quote unquote, pulling their hamstring. You have a kid that has a severe hamstring strain. They remember it. They know when they did it. Yeah, I felt my hamstring pop, right? But then you got these guys that just come in, my hamstring's sore. It just sore. I feel it all the time, but they don't have a mechanism. And what I started doing is looking, at their pelvis and being more thorough with that, because I think it's so easy to overlook that area. And when we found that in guys with just that chronic pain and corrected it, it's like a magic bullet. It's like it goes away really, really quickly, because they don't have a true, quote unquote, strain. Now, I do think they're predisposed to it if you don't fix it, but that's a pretty interesting thing that we've paid more attention to.
Before this webinar started, kind of just as an aside, I was actually on a call with Australia, Brisbane, Australia, and the guy that created the Norboard. So I was talking to the Valve people, the company. And it was interesting because as we were talking, he had said, well, everything that you said, Jeff, in addition to, obviously, you look at pelvic control. So That's a great question that that participant asked, because even the person that invented the NOR board, which he believes is a key component, also believes in pelvic control, the extensibility of it, as you mentioned, flexibility, and the length of the muscle itself.
That's great. And some of these other assessments, you know, again, focusing on hamstring for another brief minute. Jeff, you mentioned that you do an overall assessment for a lot of your athletes. Is there a specific measurement that you look at for hamstring flexibility in particular, which again would, you know, theoretically correlate with this idea of a shortened fascicle length?
No, we really don't. It's something that we bounced around talking about a lot. I mean, we have done some goniometer measurements and things like that, but we really don't dive that deep. Maybe it is something we probably should look at. You know, the problem with a lot of the movement analysis, which I'm a big believer in, is just the logistics and the time, right? I mean, they're stretched for how much time they have, and you know, you've got to really be you know, strategic with how you with what you do, you know. So that's difficult. I do think there's value in it, but we really hit the eccentric evaluation hard with the Nord board and kind of take it from there.
That's great. And then, you know, the question for really everybody, because I think this kind of spans all areas here in terms of, are there any pearls that you have for this idea of proximal hamstring strain near the tendon or tendinopathy, you know, in terms of treatment, in addition to maybe some eccentrics that we've obviously clearly covered? And then when would you consider maybe, you know, the therapy aspect, stretching aspect, eccentric strengthening may warrant something else, such as an injection or even eventually surgery? That's for everybody.
Yeah, the proximal hamstring syndrome is clearly a real entity, and we don't see that much in the young athlete. This is more the middle-aged individual that has, you know, more of a chronic hamstring situation. But I think the precursors to that are obviously going to be very similar to what predisposes you to hamstring injury. I mean, anything that overloads the tendon is going to lead to that. So, I mean, obviously you're not measuring fascicle length in a 45-year-old CrossFitter, but like Jeff said, assume everyone's got short fascicles and weak eccentric hamstring strength, and I think you could potentially prevent a lot of that.
Yeah, from a treatment standpoint, Mike, I mean, I would use shockwave therapy. Even though you're going through pretty good mass, you can kind of move a little bit of the soft tissue out of the way and get on the ischial tuberosity. But shockwave, laser, flexibility, eccentrics, that would be my approach.
That's great. Moving back towards more core muscle injuries, specifically for Dr. Emblem, what specific MRI protocol or views should someone ask their radiology department to identify to really look at a core abdominal injury? And what findings should they evaluate for professional athletes that may end up needing a surgical treatment? This is from Dr. Sal Montenegro.
Yeah, I remember Sal. He was a fellow when I was a resident. Hey, Sal. Basically, it's an oblique axial, which is a very, you know, the pelvis relative to, as mentioned, can have a varying degree of tilt. And a true coronal is not a true coronal of the, or a traditional coronal is not a true coronal of the pelvis. Neither is an axial. So it's finding that exact coronal of the pelvis, and it requires some tweaking of within the gantry of the MRI machine. What we can do is if anyone's interested in obtaining that MRI protocol, they can certainly email ASMI. I want to say the email address is info@asmi.org, and we can provide that. In terms of professional athletes or college athletes or any athlete for that matter, the ones that tend to be heading in a direction of failed conservative treatment is when that pain level or those provocative testing maneuvers come up above the pubis and extend into the terminal insertion of the rectus. Those are the ones that typically have a difficult time recovering. So if someone has an acute injury to their adductor, you know, a lot of those are just adductor strains, but the ones that persist and start to extend up into the rectus abdominis are the ones that are typically more problematic.
Along those same lines, there's a question from Adam Rosowski. With respect to that same sort of entity, when you're looking at MRI, where the extent of the injury kind of traverses multiple muscles, is there do you see commonly stress reactions at the pubic rami in association with that? And is there a different way of approaching that if you do see that?
Absolutely see a lot of changes in the pubic rami, and I think it's more of a tension related phenomenon. It's a lot of this is a pulling effect on the periosteum, particularly in the pure athletic pubalgia kind of early phase or the osteitis pubis. And that's why we use Indocin a lot of times in the treatment for a lot of these kids and athletes that don't have hard findings on their physical exam or on their MRI, but because for some reason, I can't explain it, Indocin from a therapeutic standpoint appears to really concentrate itself in the periosteum, which is where a lot of this periosteal pain occurs around the pubic rami. So athletes that have pubic pain and soft findings on their scans, it's worth giving them a trial of Indocin because a lot of times you can ward off a lot of the symptoms just with medicine alone.
Gotcha. And along the same lines of looking at possible, surgical indications for core muscle injuries, one of the questions from Daniel Solar: would a protrusion in the pubic or inguinal area, accompanied with a snapping sensation during hip and trunk flexion exercises, be an indication for a surgical repair, although no true discomfort is experienced?
That would be an indication to certainly see a general surgeon, in my opinion. That's gonna alert me more for a femoral hernia, Spigelian hernia, maybe even an inguinal hernia with a snapping hip. And that's why I mentioned it's important when it gets outside of that little box, in the box specifically being the rectus and adductor, you need to start gathering your troops and having general surgery take a look at them, maybe do some different types of studies just to make sure we're not operating on something that it's not. So like what we showed in our paper, it's the same to the contrary. If a patient has an inguinal hernia and we're doing the surgical operation that we do for a core injury, it's not going to fix the problem.
One last question by Barry Henry, kind of somewhat related, but when you talk about sartorius, rectus femoris, common hamstring origin, apophyseal injuries in younger athletes, do you think there's a common injury pathway or theme that's similar to core injury or sports hernia? As suggested, meaning fatigue, tightness, or is it more of a single instance force overload?
In terms of hamstring?
When you look at hamstring origin, rectus femoris, sartorius, and apophyseal injuries in younger athletes.
Oh, apophyseal injuries. I'm sorry. Yeah. So absolutely. Yeah. Rectus femoris off the AIIS, sartorius off the ASIS, and hamstring off the ischial tuberosity. So in general, in adolescent athletes, those growth areas are the weak point. And what we're seeing, and Kevin and Jeff and yourself, Mike, can attest to this, is these kids. I saw a 13-year-old boy last week with that precise injury and ischial apophyseal injury. He's 6'1". Okay, he's squatting in the weight room 6 days a week. He's more developed than I ever was, and he's 13, and he's got an apophyseal injury off his ischial tuberosity. So, again, I mean, you can overpower these apophyseal centers and avulse them. So flexibility and moderation in terms of working out and strength training is critical in trying to avoid these.
Yeah, I think there's such a lack of emphasis on just general core strength. You can have overall strength, but they just don't have that foundation. And we've seen that a ton with our athletes. Years ago, we were having a big issue with skill guys with athletic pubalgia. And I know Dr. Emblem and I and Dr. Kane, I mean, it was driving us insane with what we were seeing. And, our director of rehab, I think, is listening to the talk, Jeremy Giselle, and he, he really helped us, to kind of figure out what are we missing here with this issue. And really, we found we were doing too much too soon with our new players. I mean, you may have a guy that's an incredible athlete and they're strong and they can go in that weight room and they can squat, but really they don't have the core strength and the pelvic stability to be loading up with a lot of weight. And that evaluating the core strength with that simple single leg wall squat really kind of opened our eyes, because you would have these guys that were quote unquote strong with their Olympic lifts that couldn't hold that and couldn't do that. And that's when we said, we need to back off. And Kevin, I don't know if it was you or somebody gave me this analogy. It might've been Dr. Myers years ago. He said, when you have this athlete who's super strong like that with a weak core, it's like firing a cannon off of a canoe. It doesn't work, that's something that's always stuck with me. The simple things tend to stick with me. That's always stuck with me.
It's a good one.
Yeah, I like that. That's a great way to describe that. Looks like we've really answered a lot of the audience questions and a lot of the questions I had for the three of you. Any other questions that the three of you have for each other, or any sort of last sort of comments?
No, I think this has been a great masterclass series. I think these are two areas that are challenging to anybody involved with sports medicine, whether it's a physician, an athletic trainer, therapist, combination, or something that I didn't include. And by God, if we could figure out how to avoid core muscle injuries and hamstring strains, we could run away with it. So appreciate all the input from the other guys for sure.
Yeah, I would second that for sure. Certainly don't have all the answers. We'll probably have a hamstring strain tomorrow in our training program. So good luck to everyone on it. It's kind of one of those things that you're going to be dealing with, and I don't think you can ever stop it. Just want to minimize it.
Yeah. Don't forget the core. Don't forget posterior chain. I don't think you can go wrong with those two concepts. And as Jeff mentioned, I think it's really good to think that everyone is tight and everybody's weak in their hamstrings. I think that's a great approach. I would say the same thing about the core. Assume everyone is weak in the core and try to do a combined program. I love the bridging on the stability ball. We do that with everyone. We do it concentric. We do it eccentrically. I think it's just an important proprioceptive neuromuscular exercise, but it combines core with your lower extremity.
Excellent, guys. Well, I really appreciate all the insight all three of you shared from the surgical side, from the non-surgical side, from the rehab and preventative side. I think everyone else from the comments really enjoyed this. So again, Dr. Benson Emblem, Dr. Kevin Wilk, Jeff Allen, and Dr. James Andrews here. Thank you guys so much. This was excellent. Look forward to another one sometime in the future.
That was a great meeting, man. Great meeting.
Dr. Andrews, after listening to Mike's podcast and him moderating tonight, if he becomes disabled or surgery becomes obsolete, I think he missed his calling. He can be a game show host or a professional podcaster.
Yeah, but I learned about the core tonight, so I don't have to send them to you for surgery anymore.
That's right. We'll send them down there to you.
No, I give up. No, don't do that. Y'all keep working on it.
All right. Everybody take care.
Thanks, guys.
Thank you.
Have a great
night.
night. Thanks, everybody.
Great job, Mike. Excellent job, Dr. Ryan.
Thank you, sir.
See you, Jeff.
Take care, guys.